Good afternoon. My name is Aman B. I'm a general surgery resident from Houston Methodist Hospital. Today I'll be presenting on robotic and peroral endoscopic myotomy have fewer technical complications compared to laparoscopic hilar myotomy. I have no disclosures. None of the authors have any financial activities relating to the study. Achalasia is the most common primary motility disorder of the esophagus with about 5,000 cases per year. It manifests with abnormal esophageal peristalsis and failure of the lower esophageal sphincter to relax. One of the main symptoms associated with achalasia is progressive dysphagia. Treatment of achalasia, whether surgical or non-surgical, is focused on decreasing the lower esophageal sphincter resting pressure. To obtain this, different treatment modalities have been used, such as pharmacologic treatments with calcium channel blockers, nitroglycerin injections, botulism toxin injections, and pneumatic balloon dilations. However, these treatments have high recurrence rates. The standard surgical option is a laparoscopic hilar myotomy with fundoplication. New approaches for esophagastric myotomy are peroral endoscopic myotomy and robotically assisted hilar myotomy with fundoplication. Hilar myotomy has become the standard of care in many hospitals for patients diagnosed with achalasia. Hilar myotomy via a laparoscopic or a robotic approach is often accompanied with a partial fundoplication to prevent postoperative gastroesophageal reflux. Generally, the myotomy is extended 6 centimeters proximal to the esophagastric junction and 2 centimeters distally onto the stomach for a total length of approximately 8 centimeters. The longitudinal and circular muscle layers are divided and separated to expose the mucosa. An anti-reflux operation, such as an anterior or posterior partial fundoplication, is often performed. During peroral endoscopic myotomy, an intentional mucosotomy is created in the mid-esophagus, through which a submucosal tunnel is created. This tunnel is extended 2 to 3 centimeters beyond the esophagastric junction onto the cardia of the stomach. Then, a distal to proximal myotomy is performed to divide the circular muscle fibers and to preserve the longitudinal muscle fibers of the esophagus. The intentional mucosotomy site in the mid-esophagus is then closed with endoscopic clips or sutures. In our institution at Houston Methodist Hospital, both POEM and robotic hilar myotomy were introduced during the time when laparoscopic hilar myotomy was a standard approach for treatment of achalasia. Our hypothesis was that both POEM and robotic hilar myotomy have equivalent amount of technical complications as laparoscopic hilar myotomy. We conducted a retrospective review of patients who underwent laparoscopic hilar myotomy, robotic hilar myotomy, and peroral endoscopic myotomy between 2013 to 2017. The POEM data was prospectively collected, while the laparoscopic and robotic hilar data was collected using hospital database and electronic health records. We collected data on patient demographics, comorbidities, patient characteristics, and surgeon information, morbidity, length of stay, and 30-day readmission rates. Technical outcomes were also recorded, including full thickness injury, conversion to open surgery, and unplanned return to the operating room for delayed perforation. Differences between the groups were evaluated using chi-squared tests for categorical variables and the Kruskal-Wallis test for continuous variables. Univariate exact logistic regression analysis and multiple logistic regression modeling were performed to determine the characteristics associated with combined technical endpoints. There were 171 patients who underwent esophagastric myotomy. The average age was 57 years old, with 58% being male and 42% being female. These patients' preoperative history included hypertension, gastroesophageal reflux disease, hypercholesteremia, smoking, diabetes, and obesity. 46% of these patients had previous abdominal surgery, with 7% having surgery at the gastroesophageal junction. Of the 171 patients who underwent esophagastric myotomy, 40 were laparoscopic hilar myotomies with partial fundoplication, 44 were robotic hilar myotomies with partial fundoplication, and 87 underwent a POEM procedure. Laparoscopic hilar myotomy group had a higher number of surgeons performing this operation with 9 surgeons, while robotic group had 3 surgeons performing a range of 2 to 35 cases, and the POEM had 1 surgeon performing all of the cases. There were significantly more patients with a preoperative history of gastroesophageal reflux disease in the laparoscopic and robotic groups compared to the POEM groups. Moreover, there were significantly more patients in the POEM group with a history of arrhythmia compared to the laparoscopic and robotic groups. Furthermore, there were more patients with a history of hypertension in the robotic group compared to the laparoscopic and POEM groups. Finally, there were more patients with congestive heart failure and in the robotic group compared to the laparoscopic group. There were no significant differences in the history of coronary artery disease, myocardial infarction, asthma, diabetes, hypercholesteremia, obesity, cancer, previous abdominal surgery, surgery at the GE junction, smoking, or alcohol. When all the technical outcomes were combined, there were significantly higher rates of technical complications in the laparoscopic group compared to the robotic or POEM groups. There were no differences among the groups in the conversion to open or unplanned return to the operating room for delayed perforation. However, there was a significantly higher rate of full thickness injury in the laparoscopic group compared to the robotic group and POEM groups. There was no correlation between the number of laparoscopic hilar myotomies performed by the surgeon and the rate of technical complications. There was no significant difference in the morbidity, length of stay, 30-day readmission rate, and mortality among the groups. Multivariate logistic regression showed that laparoscopic hilar myotomy, history of myocardial infarction, and history of smoking were all risk factors for developing a combined technical endpoint. We looked at the laparoscopic group more in depth, which had the highest number of surgeons. We analyzed the relationship between the number of cases performed by the surgeon and the technical complications. There were 9 surgeons who performed 1 to 13 cases during the study period. We found that there is no correlation between the number of laparoscopic hilar myotomies performed by the surgeon and the combined technical complications, with a p-value of 0.3. 2 of the main limitations of this study, one being that it was a retrospective review study. However, the POEM data was prospectively collected, and using a comprehensive electronic health record, the chart review for the laparoscopic and robotic data was thorough. Second, it was a single institution study. However, it included 5 years of data performed by 10 different surgeons. In conclusion, robotically assisted hilar myotomy and POEM are safe and efficacious treatments for achalasia with lower rates of technical complications compared to laparoscopic hilar myotomy. Robotic surgery and POEM should be considered in the treatment of achalasia. I want to thank Dr. Kim and the rest of the authors for helping me with this study.